skin spots. I'm just so thankful for everyone who joined, and I just want to say that with everything that's going on, I'm really thankful that technology does allow us to be close and together. So thank you everyone for being here today. And I'm, Lisa, I'm not being able to advance. I don't know if my screen is locked.
Yeah, try clicking on your slide. And so click on it and then try it.
Oh, there you go. Thank you. All right, great. So I just want to let you know today I'm going to be talking about benign skin lesions. These are the benign things, spots, little bumps and lumps that we all have, but they are very common reasons for visits in the dermatology office, because sometimes they look funny and sometimes they show up out of nowhere and people are just curious if they can be anything. So that's the focus of this webinar today. I will not be talking about skin cancer. Skin cancers will be actually discussed in a separate webinar just on signs and symptoms of the various common skin cancers we have. May is Skin Cancer Awareness Month. So we thought it would be very fitting to have a webinar on skin cancers in May. So like I said, today we're going to be talking about benign skin lesions. I do want to also say that this webinar does not substitute a clinical evaluation by your board-certified dermatologist. Even if you, I'm going to show a lot of photos, and if you think something that I'm showing looks exactly like what you have, I just want to let you know that please confirm that with your dermatologist, especially if you have any new lesion, anything that's growing, changing, bleeding, scabbing, or just unusual looking. Make sure to have that checked by your dermatologist. So I want to start by showing you a number of different lesions. They all are common and happen with many people, but what do they all have in common? And what they have in common is that these are all benign lesions. They're not harmful. They're not going to become anything bad. And these lesions, they may be new. They may be growing, they may be unusual looking, they can be quite intimidating looking, but they are benign. And that's just to make a point that benign things can look funny, and malignant things, skin cancer, can sometimes not be so harmful looking or unusual looking. It's very common that someone comes to me in clinic to have one of those lesions looked at, and they're very concerned about the appearance. And during the exam, I give reassurance of the benign spot, but I find something else that happens to be a skin cancer, and it was not something that the person was worried about or even noticing as well. So please bear in mind that if you have any questions, have your dermatologist look at it. Dermatologists spend a lot of time in training being able to differentiate benign and cancerous lesions. So that's what we're here for. So I'm going to get started now. The first lesion that I want to talk about is something that I'm sure many of you who are watching have. It's called Seborrheic Keratosis. They're often called barnacles. Patients like to call them age spots. I like to call them wisdom spots. I think it's a better spot, especially since I got my first one. And usually these are rough, but they can be smooth as well. But often they're rough spots on their skin. They're just growths on the skin. They happen out of nowhere. And they can have many different colors. They can be just skin color, yellow, sometimes pink, gray, brown, or even just plain black. They can be asymmetrical, they can have different colors in the same lesion, they can grow, they can just do all the wrong things, but they do not have a malignant potential. They are benign lesions and they do not turn into cancer. So these are very common. They don't need to be treated. Sometimes they get inflamed and we treat them because of they get rough and inflamed and painful and scab. So we treat them with cryotherapy, which is liquid nitrogen. We freeze them. But just to give you an example, of more photos of benign seborrheic keratosis. And if you might have heard the term S-case, I think dermatologists abbreviate that very often, so that's what we're referring to, it's S-case. And as you can see, they're very common. They can happen on the face, on the scalp, around the neck, on the back, chest, trunk, and extremities. They pretty much can happen anywhere. They're benign spots, as you can see, but they can be funny looking. A lot of times, patients are really concerned about the appearance of those lesions, and they present to me several different lesions, and I tell them they're all seborrheic keratosis, but they look so different from each other, and that's just the nature of this condition. If a dermatologist see a lesion and we are in question, we can use something called a dermatoscope, which is a little magnifying light that we are trained to use and recognize patterns on different skin lesions, and those patterns will help us make a diagnosis. And seborrheic keratosis can have many different types of patterns, but they all point to the benign nature of the lesion. And sometimes we're still in question, even after we look, most of the time we can diagnose them with our naked eye, but even after looking, examining, feeling, using a dermatoscope, we may still question the nature of that lesion. A biopsy can be done and give us the correct diagnosis by just looking at that lesion under the microscope. So I'm just going to move on now to a very common spot called cherry hemangiomas, and people call them my red dots, my rubies, my jewels, several different names. I feel these are more often perceived as benign by patients. People are more used to those. They say, well, my father had a lot of those, or have a lot of those, has a lot of those, and they feel more reassured about cherry hemangiomas than by seborrheic keratosis a lot of times. So cherry hemangiomas, most people have them. They're little bright red dots on the skin. They can be very tiny. They can be a little larger too. They're just blood vessel growths. These are benign. The number of those lesions will increase with age. They have no need for treatment, but sometimes they can, for some reason, be not very cosmetically pleasing to a patient, and in that case, they can be treated or removed. More for cosmetic reasons. They are, like I said, benign. They can happen anywhere, so you can see even on the face, but more commonly we see them on the trunk. Cherry hemangiomas, like I said, they're usually perceived as benign by patients, and the doctor will just reassure the patient of their benign nature. But sometimes they can be, especially when they're very bright red color, but sometimes they can be purple or even black. And that's when I feel a lot of patients bring them to my attention because they're concerned. Usually we can, by naked eye, tell them they are benign. But if we have any questions, like I said, we can use the dermatoscope and see the classic pattern of the vascular nature of the lesion. And rarely we may biopsy. I feel like sometimes biopsy is not really used because it's such a straightforward diagnosis, but if needed, a biopsy will confirm the benign nature of the lesion. I'm going to move now to lentigines. Lentigines are the brown freckles that we get with sun exposure with age. They are often called age spots, but they're really not age spots. They're really sun damage spots, because we rarely, or if ever, we're not going to get them in areas that the sun never shines. So it's usually very common on the face, very common on the V of the neck and the hands, where we get the most sun. We don't need to do any treatment. These are benign, but a lot of times people do want them treated for cosmetic reasons, and there are many modalities of treatment to get rid of them. They're very common on the face, like I said, and often we see more of the left side affected, mostly because of the driving sun. And like I said, those are brown, benign appearing freckles, but sometimes they can look unusual, and I'll show you. that we do biopsy them sometimes for that reason. So again, just showing you a lot of photos to illustrate that they happen on the top of the shoulders, on the chest, on the hands. Those are the areas that you get more sun. And the dermatoscope can be used, but if in question, if you have one of those brown freckles just looking a little unusual, biopsy can be done to confirm, because we do have brown spots high on our radar to make sure they're benign when we're examining a patient. Our focus of the dermatologist is really trying to make sure that person does not have a skin cancer, especially a melanocytic type of skin cancer called melanoma that can look brown a lot of times. And I'm just going to now talk about skin tags. Skin tags are those tiny, sometimes they can be bigger, but usually small little soft skin color, sometimes brown bumps on the skin. They stick out. And because of that, they can be quite a nuisance because they can catch on necklaces, they can catch on clothing, they can become irritated by that. Skin tags are common, exceedingly common. There are some conditions that make people more prone to skin tags, such as diabetes, obesity, but skin tags can happen to anyone. They're very common on the neck and axilla, but they can happen in other parts of the body as well. They are completely benign. They have no malignant potential. They're more of a nuisance than anything else. And no treatment is necessary, but a lot of times patients do want to have them removed, again, for comfort or cosmetic reasons, and that can be done in the office as well. A few other examples of skin tags, and as you can see, sometimes they can be a little bit bigger, so they can be more a nuisance to the patient. Another very common lesion that we see in the office every day, the patients happen to notice them suddenly and are worried about them, is this condition called a milium, or in the plural, milium. They are very tiny, white, kind of firm, or sometimes yellowish bumps. These are tiny cysts. They are little tiny cysts that grow under the skin. And they are common, very common. Rarely we have some conditions that, genetic conditions that can be associated with them, but those are very rare. The vast majority of cases we see are just sporadic little milia. Some people are just more prone to make them. They can be extracted if needed, but they're benign. They pose no risk, and they can just be left alone as well. One more condition is the sebaceous hyperplasia. Again, very common. Sebaceous hyperplasia is quite an interesting lesion. It is an enlarged oil gland, or a collection of enlarged oil glands. They're usually yellow, pink, orange looking. They can be a little shiny. They sometimes have little vessels around them, and often they have a small little divot. We call that an umbilication. They have a small little divot in the center. That's their kind of classic appearance. They're completely benign, but sometimes because of their appearance, we can, if we look just quickly, we can think that could be a type of skin cancer called basal cell carcinoma. So often, just by the naked eye, we can tell these are just benign oil glands, enlarged oil glands, nothing to worry about. But every once in a while, I do feel the need to magnify them and look under my dermatoscope to give me that reassurance that this is a sebaceous hyperplasia. They have a very characteristic look under the dermatoscope. And if needed, a biopsy can be done again. And in that case, it looks very characteristic under the microscope as well. I'm showing you some photos of the microscopy, not because that's that's just for curiosity, for in case you wonder how those look under the microscope. I do want to talk about actinic keratosis. Actinic keratosis is a pre-malignant condition. So not a skin cancer yet, but a pre-malignant condition. It's a lesion that has a potential of becoming a squamous cell carcinoma, which is a skin cancer. Actinic keratosis is very common. They happen in areas that are chronically exposed to the sun, day after day, year after year, or throughout several years. Those are the areas that get actinic keratosis. So we see them very often on the scalp of men, or of bald men, on the ears, top of the ears of men, on the face, and dorsal hands, dorsal arms. Those are very common spots, just areas that get sun chronically. Actinic keratosis, they're not always, I got 2 photos to give you some examples, but they're not always visible. Sometimes they're just, it's more of a feel than something you see. They are rough spots on their skin, on the skin. They can be red, they can be yellow, but sometimes it's just something that you feel when you run your hands. So usually when I'm examining the face or the ears or scalp, I'm usually looking, but I'm also feeling for those areas and palpating, because sometimes I don't see them, but I very easily can feel them. This is a diagnosis that we make every day in the office. They're very common. And they are the spots that, if you've been to a dermatologist and had stuff frozen, that's very likely what was frozen, the actinic keratosis. We treat them with cryotherapy very often in the dermatology office. Actinic keratosis can be treated in other ways as well. There are patients who just happen to have numerous of those lesions, not just 1 or 2 or 3 that I can easily freeze individually, but they just happen to have more what we call of a field of lesions. And we know that there is more than we can see or even feel when we see a patient with a field of actinic keratosis. We know that even in areas that look normal, if we were to look at them under the microscope, we would see changes of atypia that are caused by the ultraviolet radiation. So in cases like that, often we can use things that treat the whole field, such as a cream, a topical chemotherapy cream, a topical immunomodulator that just activates the immune system to fight against those lesions. Those are topical treatments. And there's also another field treatment called blue light that is employed to just treat the whole field. So actinic keratosis, we do treat them. These are something that we do offer treatment for those, and we do want to treat them because they can become skin cancers. And again, rarely we need to use, I would say it's very rare to have to use a dermatoscope for those lesions. They are very easily diagnosed just by feeling. But sometimes if they're a little bit thicker or they have a little sense to them, we want to make sure they haven't made that transition into early stage squamous cell carcinoma, and sometimes a biopsy is done. And to finalize this webinar, excuse me, I'm going to talk about 2 very common conditions that happen under the skin. These are not skin lesions, but they happen under the skin. But they're so common that I thought it would be a good idea to include them here. One is the epidermoid cyst, or people call them sebaceous cysts. Very commonly, the correct name is epidermal inclusion cysts or epidermoid cysts. These are small cysts, or they can actually grow to quite large sizes. They happen under the skin, and often they are asymptomatic. They cause no problems. They grow slow, and they really cause no problems. But they can become infected, and they can grow to substantial sizes. So when they become infected, that becomes a problem. They become painful, red, inflamed. They can turn into an abscess, and then they do need treatment. Any lesion, we recommend that any lesion that's growing or hurting should be removed and evaluated. So that's a common finding on skin exams are epidermoid cysts. I often get asked, why do people get epidermoid cysts? And the truth is, we just don't know. It's just something that people get. There are some cysts are very truthfully epidermal inclusion cysts. That means something happens that they got a little bit of skin got included or inserted into the skin and a cyst grew. For instance, sometimes they happen in a line of suture where you had suturing or stitches before, and maybe that was a trauma that caused a cyst to be formed. But the vast majority of cases are sporadic, meaning they just happen and we don't have an explanation for why a person got an epidermoid cyst. And I get that asked often because patients want to do something to prevent. And unfortunately, I just don't have an answer on how to prevent them. Once they are removed, the technique to remove is actually to come to a dermatologist, that area gets numbed, and the whole cyst is removed. Not just the contents, but the actual lining of the cyst, which is the capsule. And once the whole capsule is successfully removed, the chance of that cyst coming back is pretty small because you don't have any cyst material left. A second thing that I want to talk about are subcutaneous growths called lipomas. Again, very common. And lipomas are benign little fatty growths under the skin. Most people have sporadic lipomas, meaning they have one, maybe two, but that's it. But some people have a familial condition called benign familial lipomatosis. That means they just happen to have multiple lipomas, and they can happen anywhere in the body. They they can be felt. They're not usually visible. This is a good photo that you can actually see the bump, but a lot of times you just don't see them. You can feel them very easily, but you can't see them. But sometimes they grow to sizes that actually become prominent on the skin and then they become visible. An excision of a lipoma involves numbing the area, making an incision on the skin because you do need to get to that subcutaneous area, and then removing the lipoma and putting stitches. So often I tell patients, if they are bothered by their lipoma, enough to trade them for a small scar, because sometimes they are not visible and they can just be left alone as long as they're not growing or hurting. But sometimes they are symptomatic, they are painful, and patients would much rather have a small scar than to have the lipoma. And with that, I conclude. I just wanted to give you an overview for many benign spots that we see in clinic often. And I'm happy to answer any questions. I hope it was useful. And like I said, if you do have a spot that you're not sure about, even if it looks exactly like one of the benign spots I just showed you, but you're not sure, or if it's growing, or any new spot that's growing, please see your dermatologist.
Great. Well, thank you so much, Dr. Prado, for sharing with us. For everyone who is logged into this webinar, down at the bottom, you will see a Q&A function. Feel free to open that, type in any questions that you might have for Dr. Prado, and she'll answer those. And so, Dr. Prado, we have the first question that is being submitted here. It asks, would an actinic keratosis be on the nose? No color, but rough feeling.
Yes, I would say actinic keratoses are very often seen on the nose. That's a possibility. I can't speak for the particular lesion you're asking about, but it is very possible that actinic keratosis happen on the nose. In fact, it's a very common location that we see. And often there's no color, just like you mentioned. It's not a visible lesion, but you notice this rough feeling. A lot of times patients tell me, oh, I have this dry spot and I put moisturizer, but it always comes back. It's this exact same spot. It's always on the same spot. And I put moisturizer, I put Vaseline, I put, all emollients that I have, and my whole skin is well moisturized, but this rough spot is just this dry skin that I have. And then I tell them it's actually not dry skin. It's actually the reason why it's not responding to a moisturizer is not because the skin is dry. It's because the cells that make that skin are atypical. And that's what an actinic keratosis is. It's the cells that are supposed to make healthy skin they are making atypical skin, and that's why the skin looks rough, feels rough. So that's correct.
Okay. Now, Dr. Prado, we have a question coming in. It asks, is there a benefit for cryotherapy over topical treatments, specifically for actinic keratosis?
Yeah, so I feel they both play good roles on treatment of actinic keratosis. But usually cryotherapy is reserved. I would say the vast majority of patients that come, they can be successfully treated with cryotherapy because they have lesions. They have like one lesion here, one lesion here, one lesion here, and we can feel them. They are distinct, and we can treat them with cryotherapy. The benefit of, so let me give you the pros and cons. The benefit of cryotherapy is that it's done in the office. So I will do that for you. And once you leave, you're done with your treatment. It will scab the site that was treated with cryotherapy. It's liquid nitrogen, very, very cold. It freezes the skin cells. It will scab, and then it will fall off. And then at that point, if it was successful, the skin would feel and look normal. So that's one thing. The benefit of topical treatments is for people who have multiple lesions where cryotherapy would just not be possible. There are just too many to freeze. The topical treatments are something that I would prescribe, and you'd be the one doing it. So, and it's not a one-day thing. It's something that you have to do through a course of days. It depends on each medication. They all have different timelines, but it would be something that you'd be doing through the course of days. And they usually do make your skin very red, very inflamed, and all the little precancers are going to react, and they're all going to become red and scabbed. So it will probably take you away from maybe your social obligations if you're very inflamed for a while. Some people just don't feel comfortable with the looks of it, but that's temporary. And once you finish the treatment, you will be, your skin does resume to slowly getting less and less red, and then resume to normal, and all the rough spots will be gone. So it is, they use in different situations, cryotherapy, I feel like when you have a limited number of lesions, and topical treatments when you have a field.
Great. Now, Dr. Prado, we have a question coming in. It's actually two questions coming in from a participant. Are there ways to prevent these spots, and any known ways to prevent lipomas?
I'm assuming the person is asking ways to prevent the benign spots that I talked about. So I talked about seborrheic keratosis, cherry hemangiomas, skin tags, milia. All those spots, unfortunately, they're not preventable. They do carry a genetic component to them, and you may just get them. If you're talking about lipomas, any ways to prevent lipomas, unfortunately, also no. A lot of people ask me, am I eating something that's causing the lipoma since they're fatty growths? And the answer is, unfortunately, I wish I had an answer that I would say yes, but unfortunately, no, we can't prevent them. We just happen to get them. But if you are asking about actinic keratosis, then the answer is yes. That's probably the only thing I talked in my whole talk that is preventable. Actinic keratosis are preventable with good use of sun protection. So sunscreen, sun protective clothing, hats, sunglasses, and staying away from the sun during the peak hours consistently throughout the year.
Great. Well, Dr. Prado, we have another question coming in. If a previously benign mole becomes slightly more raised and itchy, should that be a cause for concern?
I would have it evaluated. Yes. Any change in a pre-existing mole, it may be nothing. It may just be that it is inflamed. Some moles have a hair follicle within them. They can be inflamed. So it could be nothing, but I would, if you have a pre-existing mole that's changed, I would have it checked. And if you have a new mole that happens where you didn't have a mole before, especially if you're over the age of 30, I would have it checked as well.
Okay. All right, we have someone who is thanking you for your time, saying this is very informative, and also has a question. Do you have a recommendation for an over-the-counter lotion to use for dry skin?
So many good lotions. I would say I can give you a few names. I say you don't need to go expensive. A lot of people like the expensive stuff, but if you're purely wanting to solve dry skin problems, you can very easily use Vaseline. There are great moisturizers by CeraVe, by Neutrogena. There is one called Nivea Soft that I personally like a lot. Rachel and Megan actually did a webinar on dry skin, and they have a list of lotions. And we have your name. I'm happy to send it to you or make it available to you.
Great. And then we have someone who's asking, on the back of my hand, I have a spot that was previously frozen based on actinic keratosis diagnosis last year. Now it builds layers that start to peel off, yet not readily. Ordinarily, I would have gotten this checked already, but with COVID-19, I've hesitated. How soon should I get this checked again?
All right. One thing is the back of the hand is a very common spot for actinic keratosis. And sometimes patients even say, oh, I think I had this one frozen last year or before. And it may be a separate one because it's just a common area. And you may have what we call, a field of changes that you can have multiple spots. However, an actinic keratosis can recur if it wasn't fully successfully treated. So what I tell my patients when I'm freezing their spots is say they should scab, they should fall off, and then it should feel normal. If that doesn't happen, if they recur, please come back and I need to see you again. Either to freeze it again, and if I'm freezing something over and over, at some point I stop and I say we need to biopsy this. So I usually don't want to freeze anything more than twice. If I did good two freezes, the next time I'm probably biopsying. But again, it depends and it has to be evaluated. In your case with COVID-19, two things. One, I would have it checked with a virtual visit. So a lot of dermatology practices, including Vanguard, are offering virtual visits. So you can have it photographed and checked and have it evaluated. Also, it seems like now there is this change that we might be opening, so you should probably have it evaluated, if not virtually in office, as soon as this happens. One thing that I ask patients when an actinic keratosis, what looks to be an actinic keratosis, is growing or recurring, is if there is any tenderness or any feeling to that. And that usually, even if it's very small, it looks like an actinic keratosis to me. If there is a slight feeling, patients say a little needle, I feel like there's something there. I know it's there. If there's a feeling to it, I often biopsy right away, because sometimes that's the sign of a transition from an actinic keratosis into a early stage squamous cell carcinoma, which is the cancer, the skin cancer that it gives, that comes from actinic keratosis. So I would say have it checked. It's always better to be safe.
Great. Well, Dr. Prado, thank you so much. We actually have one last comment coming in from someone saying thank you for your excellent verbal and pictorial descriptions. I would echo that. This has been really helpful. So thank you so much for making the time, and thank you for all of our participants for joining us this morning.
Thank you. Thank you.